Thank you all for making the time this morning to listen to this topic. And I hope that some of the ideas I'll present here will stimulate some questions and conversation. But briefly, I've been thinking about this topic as I think this question comes up a lot with a lot of our patients. And there's a lot of interesting research being done that increasingly focuses on the brain and aging. And I thought this would be a good time to kind of introduce these topics and how they relate to Parkinson's. So without further ado, I just want to remind people as we go along, there's a place to put in questions in the chat and we'll try to address those. We'll say plenty of time for questions. I don't intend this to go beyond, say, 11 o'clock, so we'll leave plenty of time for questions before that. So I wanted to discuss and remind folks, what is the Parkinson's disease syndrome and how is it similar or different from normal aging? And then how do those changes related to aging affect people in ways that look similar to Parkinson's disease? And then I want to end on talking about how, aging is a fact of life that we will all undergo, but there are interventions that we can think of and try to highlight as being potentially helpful for all older adults, but also adults with Parkinson's disease. So for that, I always like to start out with a video, and I think it helps people. Some of you on this webinar may personally have Parkinson's, or maybe you don't, but you have a loved one or a friend or family member otherwise who has Parkinson's. And we recognize that there are a lot of symptoms, but everyone can look quite different from each other. And so this is really a video to highlight some of the sort of more classic symptoms that we may see. We don't always see all of them in any one person, but what you do see here is this tremor. This one is a fairly classic
Raise
looking
the hand
one,
and just hold it in the air.
where the thumb and fingers are moving in opposition to each
Now do
other.
this.
And the person in this video is being asked to do a repetitive tapping motion. As you can see, they get smaller and a little bit slower with time. And they're asked to do really what should look like a full hand movement like this. And you can see
Now
it's
do
not
this.
quite able to do the whole movement. And this is a common thing that patients will be asked to do in the clinic, where they're asked to open and close, and he does it progressively smaller and slower. Same thing with the foot taps. And all of these lead a clinician to conclude that someone has bradykinesia or hypokinesia. Another way to tell is watching someone as they move around. They don't tend to swing their arms or move as spontaneously while seated in a chair. And all these things can be helpful for the clinician to detect a slowness of movement that we think is neurologic in origin. Now, this is always taken in the context of other findings. So if someone previously had a stroke or other neurologic injury, spinal cord problems, you may develop some weakness that can look a lot like slowness, but a good neurological examination can try to help tease apart the contributions of each of these. And lastly, rigidity relates to a muscle stiffness that, interestingly, a lot of patients don't necessarily complain about. I do think that most people are most bothered by the slowness. And the muscle stiffness is often something that clinicians will detect on an exam, and that contributes to the whole picture as well and can lead to discomfort too. However, any one person might have more or less or even none of some of these symptoms. And so it's important to remember how variable the clinical presentation can be. So these 4 symptoms are all called the cardinal symptoms or core symptoms of Parkinson's disease. And a question that we get a lot is, my doctor said that I have Parkinsonism. What is that? Well, it turns out that having at least 2 and ideally 3 out of these 4 signs that we've been talking about makes it quite likely that when we do look at someone's brain after death, they have positive confirmation of all the pathological findings of Parkinson's. Now, if you only have one of these symptoms, or maybe you have a couple of these symptoms, but they're really quite mild, a clinician might say that, well, I'm not sure you have Parkinson's disease, but I think you might have Parkinsonism. It's their way of saying that you may have a milder form that isn't quite clear if it's going to evolve into something more substantial, where we can be much more certain that a person has a clinical syndrome of Parkinson's disease. And we'll talk about this notion of Parkinsonism because it actually turns out it is quite common in older adults, even those who we don't think meet the clinical definition of Parkinson's disease. And I'll show you some data that speaks to this. But I think that as our population, both here in the United States and abroad, is aging, we do see more of this in the clinic. And commonly, I think patients will be told this phrase of, I have Parkinsonism and I'm not sure how to interpret. So let's go through that. Before we do that, I do want to remind folks, this is just sort of a dense summary on a slide of what Parkinson's disease represents. So at the bottom right here, really the picture of the man here, let's put it this way, Dr. Arvid Carlson. His contribution was really recognizing that there's a connection between people with clinical Parkinson's disease, which had already been described pretty well since the 1800s, and everyone knows about the classic essay by James Parkinson, for whom the disease is named after, which really describes a lot of those symptoms I just talked about in great detail. So the clinical syndrome was recognized, but it wasn't until later, through the work of several scientists, that a lack of dopamine was a very key hallmark in Parkinson's disease, and that this little amino acid, this chemical structure here, is called L-DOPA. That could be given to someone. Their brains could then convert it to dopamine, and it would make a lot of the symptoms of Parkinson's disease better for these patients. And so it led to a lot of connections between knowing that dopamine was deficient in these patients and being able to administer something that could clearly test that hypothesis that replacing dopamine ameliorated a lot of symptoms of Parkinson's disease. And while it was very difficult to detect dopamine deficiency back then, these days we have a brain scan, and I'm showing this here. This is called a DAT SPECT scan, and the DAT stands for DAT, dopamine transporter. This is a special type of brain scan, which is clinically approved for use, in which a person will receive an IV, slightly radioactive IV medication, and then put through a very quick CAT scan, like a brain scan. It's not as prolonged as an MRI for some of you who may have experienced that. And that can image the amount of dopamine. And so these two images are of a person without Parkinson's, and what you would normally see is sort of a comma-shaped structure. This is called the striatum. And in a person with Parkinson's, you can see it's diminished, and they don't have, so they've lost the tail of this little comma, so it's more like a period. That now is our direct proof of a dopamine deficiency in a person with Parkinson's living. We don't necessarily have to take a piece of the brain to discover this. But that corroborated very well with the finding that these dopamine-producing neurons, which are these black areas here you see on two sections of a very a small part of the brain deep down called the midbrain. And you see this would be a normal person with a fairly normal amount of these black pigmented neurons. And here a person with Parkinson's where they're really missing that. And it's taken scientists quite some time to discover and think about what kinds of molecular events are happening to produce these neurons premature death. And it looks like a very important protein called alpha-synuclein, which may misfold and start to collect in these pink stained clumps of protein that we call Lewy bodies now. And this is sort of where Parkinson's, the hallmark of Parkinson's, comes about. and thinking about what kinds of molecular problems are there that lead to these protein inclusions and then nerve cell death. And so this is a cartoon just depicting that these proteins can misfold and collect together in clumps. And we think that these lead to nerve cell death. So it's a very dense slide, but this will set you up for our discussion about why and how we think about aging being related to Parkinson's. Okay, so no big surprise, aging affects all of us and all parts of us. And I'm showing here 3 components that I want to address today: muscle, heart, and the brain itself. So first, the brain. We've already been talking about it a little bit, but I want to talk a little bit about age in context of brain aging. So at least in the US, we know through good epidemiologic studies, there's probably about 1 million people living with Parkinson's. That means also through epidemiologic surveillance, we can kind of get a sense of how many new cases are being detected or diagnosed each year. And it's about 90,000, which means about someone is diagnosed about every 6 minutes. Right now, we think the average age of onset is approximately in the 60s, but about 10% of people will develop symptoms and have clinical Parkinson's disease before the age of 50. And we call this young onset Parkinson's. So as you can see, people can develop it very young. And at least in a specialty tertiary referral center like ours, it's not uncommon for us to see people even, below the age of 40. I have a 29-year-old with Parkinson's, and on the same day, I might have a 92-year-old with Parkinson's. And another good example of this, as many people know, is Michael J. Fox, who was about 29 when he first developed symptoms of Parkinson's. All right, but did you know this? Dopamine content actually goes down with age. And I'm bringing up this little picture from the previous slide to remind you again how we image dopamine content. And there have been a number of studies. Now, these are healthy participants. These individuals do not have Parkinson's disease. And it's a busy graph, but what we have are women and men. And this number on representing the dots is first of all, how old a person is and how much dopamine content they have. So the higher the number, the more dopamine. And you can see these are healthy people who don't have Parkinson's, but as we all get older, we lose a little bit of dopamine with age. And so that's just helpful to know, because I think people might expect that, lack of dopamine is a bad thing. And while I think it does lead to symptoms, everyone recognizes that we all lose a little bit as we get older. Okay, so what else happens as our brains get older? This is not a human brain, but there's a lot of research being done, and truthfully, a big effort by, for example, the federal government and other scientific agencies is to understand how the brain ages, because the vascular component is very important. By that, I mean blood vessels. As we get older, blood vessels get stiffer and a little bit more twisty. This is just showing a newer technology in which they're actually able to image the blood vessels of mice in quite a bit of detail. This level of detail we really can't do in a living human being to this extent. We do have blood vessel imaging, but it just is a demonstration that as we get older, the sort of compliance and the elasticity of these blood vessels get a little stiffer. And what that means is our brains might not get the same level of good nutrients and oxygen flow as we did when we were younger. And there are a number of factors that could also help prevent this. And this is why a lot of research is being done to look at what factors, what drugs, what molecules, what and other behavioral or exercise interventions might help all of us age a little bit better with respect to our blood vessels. Sometimes people get MRIs of the brain and wonder if some of the changes they see on an MRI report, what some of these terms mean. And what we see sometimes is in all people as we get older, the brain itself will get a little bit smaller with age. You might see these fluid-filled ventricles get a little bit bigger. You might see the outer surface get a little bit smaller. And that the spaces, these normal wrinkles that you see of the brain, they're called sulci, they might get a little bit larger. And so this is just a cartoon to depict that. And so there's not often, a good question I get sometimes is there some correlation between your brain size and how well a person is functioning? There are very rough and crude correlations, but on an individual basis, MRIs of the brain right now really can't tell us a whole lot about, number one, Parkinson's disease. MRIs don't diagnose Parkinson's disease. And number two, the structure of the brain doesn't always predict how well a person functions. All right. So what else do we see from a social and public health perspective for aging? A lot of epidemiologic studies are now able to identify which factors earlier in life or even midlife, as we say, in the sort of the 40s to 60s range, what kinds of things happen in those critical years that might actually influence cognitive decline or impairment as we get older. Well, it turns out in early life, more education is protective. And so we have a lot to do in that realm globally. But in midlife, there are a lot of things that we can do. And I think no time is too late for any of these things. And that means getting hearing addressed, addressing depression and mental health, promoting physical activity, we'll talk about in some more detail. But I want to get to this next group of factors because it relates very much to the blood vessel aging that I've been talking about. And that is reducing your chances for diabetes, or if you do have diabetes, controlling it to the best of your ability with your healthcare team, blood pressure, cholesterol, smoking and obesity as well. Those are definitely risk factors that contribute to blood vessel aging. And then alcohol itself on effects on the brain, as well as social isolation. Those effects are being increasingly recognized as something, if we can modify, might help promote brain aging, healthy brain aging. So now with that, I want to talk about the heart. So we've been talking a lot about blood vessels, and this is a sort of a connection here. It's been recognized for a long time now that some people can develop Parkinsonism, like I talked about earlier, with a small p, where they may have one or a couple of those findings. Their doctor is not clinically suspicious for overt Parkinson's disease, but it may mean that they are slow or they don't walk well, and then it's thought to be due to a neurological problem. This data comes from nearly 3,000 healthy older adults who agreed to donate their brain. This is actually from the Rush University team that has been contributing this data for decades now. And these people, as they agreed to donate their brain, this group of researchers was able to correlate what slowness and gait problems look like in an older adult population who have not been diagnosed with Parkinson's disease. And it kind of corroborated what we've just been talking about, that these changes in life are associated with small strokes that maybe a person might not even feel and blood vessel stiffening. So it does happen, it's very common. And in fact, another thing to point out on this sort of graph is that this says proportion of the cohort, that's a word for a sample of individuals that have the symptom. And as you can see, by age 85, it's very common for people who are otherwise healthy and aging to have gait problems, about 50%. And maybe at the same age, around 85, 20% of folks will also exhibit some amount of slight slowness. And here on this side, it's just a way to show that, again, around the age of 80 or 85, it's common. Maybe 50% of people, as seen in this sample, will have one of those symptoms that we talked about. So it is quite common with aging. Is the heart connected? That is a very interesting question and not very clear. The heart disease is associated with many other neurologic problems, such as stroke or dementia. With Parkinson's, it's a bit more complicated. One of them that is a little bit strange is, as some of you may know, Smoking, although it's a very big risk factor for cardiovascular disease, it actually is somewhat protective of Parkinson's disease. Now, we are not suggesting people go out and smoke because there are all sorts of negative health effects associated with it, and in general probably wouldn't be good for a person's overall health. But it is one of the things that is very unusual. Here too, I'm going to point out another thing because there's been a lot of talk about using diabetes drugs to see if they slow down Parkinson's disease in clinical trials. But the evidence of diabetes being a risk factor for Parkinson's is actually kind of mixed. And so this basically, the slide is just to say that it's not altogether clear whether the same things that put you at risk for cardiovascular disease are also the same things that put you at risk for developing Parkinson's or making it worse. Now, one thing where they do kind of match up, it's sort of interesting. Moderate coffee consumption lowers your risk for cardiovascular disease and for Parkinson's disease, and so does physical activity. So we'll get to that as well in a moment. The other thing that's a little bit different in Parkinson's, usually, as we talked about, high blood pressure puts you at risk for stroke and heart disease. But in Parkinson's disease, we can sometimes have the opposite problem. Some people actually develop too low of a blood pressure, even if they may have had a need to be treated with antihypertensives or blood pressure medications by their primary care doctors. Sometimes at the point of developing Parkinson's or sometime before or even after the diagnosis, they'll notice that, oh, I'm getting symptoms of getting low blood pressure while standing up. And the medical term for that is orthostatic hypotension. This is a fuzzy scan, and what you're meant to see is that this is just sort of a section through the heart. In a living person, this is an image. And this is taking up a special radioligand that helps image the amount of basically like adrenaline to the heart, which is important. Heart is controlled by a nervous system of its own. And the person here on the left, this was well before they had Parkinson's. They have good content of this adrenaline. And then as time goes by, you see less and less. And that's an example of someone with Parkinson's who develops less of the innervation, the nerves, the sympathetic nerves to the heart, which help regulate blood pressure. So for some patients of ours, we do have to treat this, detect problems with low blood pressure while standing up, try to help them treat it, and it can be managed. But this is another example of where high blood pressure would be expected to be a problem if cardiovascular disease and Parkinson's disease go hand in hand. And in this case, they do not. They're a little bit opposite. Okay, now I want to turn our attention to muscle, which is, I think, a very interesting and important part of this whole equation. So we all lose muscle mass as we get older. The medical term for muscle loss is sarcopenia. Many of you have heard the term osteopenia. That is bone loss. That is also another feature of getting older. But sarcopenia, sarco meaning muscle, is sort of the equivalent to that. Now, while we do see it related to aging, there are other risk factors that can accelerate it. Again, obesity, diabetes, a sedentary lifestyle, or malnutrition. So there are things you can do to help slow this or prevent reduce the severity of the sarcopenia. But what's interesting is that it's been known for some time that the muscle is actually, we can view it like an organ that generates a lot of beneficial hormones. And this is just a cartoon with a lot of figures and terms that are not necessarily worth going into detail. But what these are basic hormones and cytokines, or myokines, as they're called. These are basic hormones that can affect different parts of the body, including your fat cells, your liver, your pancreas, your blood vessels, and your bone. And many of these are very beneficial for these organs. And we can't forget that the muscle itself secretes a lot of these things to help sustain healthy metabolism. And so on the next slide, I'll just walk through some of them. Muscles secrete these myokines that help maintain the muscle. They also secrete a lot of cytokines that are related in both good and bad inflammation. But sometimes good inflammatory molecules signal the other organs to help metabolize fat, promote healthy insulin signaling, promote bone production, and again, good inflammatory molecules that sometimes dampen down inflammation, which is important. Now, there's a lot of research that I won't go in here today, but it's been looked at extensively to see could these beneficial hormones also slow neuron death and Alzheimer's disease models. And by models, I mean usually mouse models. And that has been shown by several groups. And so there's been a lot of interest in developing, could we develop drugs around some of these inflammatory, good inflammatory myokines to help reduce inflammation in the nervous system. So this is another reason why we might be thinking about the muscle as our friend and as our ally when it comes to Parkinson's disease and aging in general. I want to talk about this because we don't really have not traditionally been asking folks about the number of steps that they take on a daily basis. And yet, when we come to the doctor's office, we usually get our weight checked, we get our heart rate and our blood pressure checked, we might get our temperature checked, but we don't get asked often how many steps a day we're taking. And while it is expected that as we all get older, we walk less over time, there hasn't been a discussion about, well, what's an acceptable number? Certainly, there are other medical problems that can prohibit or make it difficult, including joint problems that make it difficult to meet some of these things. But this group actually, this reminds me, and anybody who's been a parent or a grandparent of a young child, you know, you have those weight and height percentiles for children. Well, this is a steps per day chart for what an average person, both men and women, might do in terms of steps per day at various ages. So you see ages 60 to 85 represented here. And if you just start at age 60, around the 50th percentile, you'll see men and women taking between 4,800 and 6,000 steps per day around the age of 60. And that does get less as we get older, but you can get a sense of a healthy range of number of steps per day. And trust me, 13,000 steps per day is not necessary for longevity. So you don't want to overdo it either. But this gives you a sense of, you know, where most people are and what might be considered sort of a normal number of steps per day. So I think that's useful information. And we should, as doctors and nurses and healthcare teams, be thinking about how we incorporate this into the visit. And gait does change with normal aging. So let's talk about it. It does slow down. In terms of how variable your steps are from step to step, that actually can also be indicative of a risk for fall. So not just the speed of your walking, but how irregular or variable your walking is from step to step. So that's important. And it probably has something to do with both balance and strength, which we'll talk about more in a sec. Now, older adults can actually walk faster upon a request, but even with age, not just with Parkinson's, the length of each step might get smaller with age, and there'll be a number of factors related to that. And then I think a common symptom that many of us hear is that one feels just less steady. And so this issue of postural stability becomes a little bit more difficult. And but the good news about all these things is that they can be worked on. They actually can be worked on through a dedicated course of PT and strengthening and a good program that can be maintained even when you're not with the PT. So when we in research think about how much activity a person does, there's a number of ways you can actually measure it and calculate it. And nowadays with the advent of, you know, smartphones, a lot of people have maybe Apple Watches or Fitbits, and there may be other more innovative ways to capture this, but we know a lot about just sort of the natural history of how people's physical activity changes over the years, not just with aging, as I showed you on that previous sort of percentile chart that I was pointing out, but also in people with Parkinson's. And it turns out, I think for many people, without even realizing it, their daily activity is declining over the course of a year. And then an intensity level that we can measure, such as at least moderate level of intensity of physical activity, sort of based on how much you can get your heart going, that declines even more. It can even decline over 40% over 1 year without any intervention. And we know that decreased physical activity in general is linked to longevity in Parkinson. So it's something we want to promote in everyone. And also, we think it's linked to patients' reported quality of life. And so that's important to keep in mind as well. Now, there are a bunch of Fitbit trackers and little things you can wear on your waist or your wrist and even your smartphone. And this is really just to say that some of them have a bit of error when you're just walking around in the house. But if you're just walking out and about in the community or around a track, around a shopping mall, they're actually pretty accurate. And so I think people can get a lot of benefit potentially from kind of being curious about how much they're actually doing on a typical week. And I think there are a couple ways you can do that with these devices you can just buy somewhat inexpensively off Amazon or through your store. So I would say, yes, we should prescribe them in answer to this question. And this was research done by the very excellent Terry Ellis and her team. She's a physical therapist and a professor at Boston University. And so I think she would agree with this. The answer would be yes. But what about strength training? What is the evidence? Well, strength training, or in other words, resistance training is another term you may hear. There's some evidence. There's actually been quite a few studies done on this. It probably can increase or improve gait speed. It can probably do very well with balance in a way that maybe just straight aerobic training may not improve as well. And it may improve overall performance. And then, as you have been hearing, most people are trying to do things like bicycling or walking, fast walking, to sort of do something related to aerobic training. But it might mean that there's a couple of different modes of exercise that might be beneficial for different things related to mobility and aging and Parkinson's. All right, so doctor, what do you recommend? Well, aside from finding a miraculous fountain of youth, I would say start from where you are. It's always okay. I think everybody tries to do the best that they can. And I think what we try to do is help people get the help and coaching they need if they want to start from where they are and change what they're currently doing. I think exercise with the help of a PT or a trainer or an exercise class can be very helpful. We'll talk about this in the next slide too. I think PD medications can be used and they can be used to great effect, but I think there is a good balance of how to use them. And also all your other medications. A very common phenomenon, especially seen in the United States, is that many older adults are on a very long list of medications. And it may not be in someone's best interest to be on quite so many medications. And so just having the chance to periodically ask your healthcare team to review the medicines and making sure that they're all really necessary and or not counteracting each other. It's never too late to address your other brain health risk factors. So smoking, diabetes, high blood pressure, getting your hearing addressed, judicious use of alcohol, and social interaction is really important as well. So age-friendly healthcare systems, I know it sometimes feels like these days that healthcare systems, they're getting very big and complicated, and how do we help them maintain their focus on patient centricity? And age-friendly healthcare systems, this has been advanced by the John Hartford Foundation. I think that these are useful to keep in mind. So with patients, they're often thinking about mobility, their mind, and it's important, as I mentioned, to review those medications and also think about what matters to you and make that really clear to your healthcare team. We want to know so that we can help kind of guide you in the right direction. There's any number of sort of steps that one can take, but I think it's really important to know what matters most to you. So takeaways. Brain aging, it's a fact of life, but we can take steps to promote healthy aging. Cardiovascular health is similar to, but not identical to cerebrovascular or brain vascular health. The muscle is increasingly recognized as an important organ for brain health. And then keep in mind the judicious use of medications and remembering what matters most when talking with your healthcare team. So with that, I'll stop and I will open it up for questions. Someone has asked, why does CL or carbidopa levodopa stop working eventually? It would seem that even as dopamine producing neurons continue to die off, giving more and more CL would continue to replace the dopamine and so continue to improve the PD symptoms. Great question. We talk about this a lot. So it turns out levodopa, when you give it early on, you have plenty of neurons to kind of take it up and store it in a pool. In fact, dopamine and most of our neurotransmitters in our brain are actually stored as little packets called vesicles. And when the neuron decides it's time to release it, that's when it can call upon the pool of neurons. But we think that in Parkinson's and other diseases where they're affecting the nerve cells that actually contain the pools of dopamine, they're less able to take that levodopa and store it. And so that's why people might experience that. At the beginning, they may not have needed to take their levodopa very often, but a few years on, they might find that they have to take it a little bit more often simply because they can't store it as well as they used to. And so it's simply just trying to replace it. And so for some people, they need a little bit more continuous dopamine replacement. Some of those types of therapies now exist and we offer them here. But this is the reason why we think it can have shorter effect. What do you mean by judicious use of Parkinson's meds? Yeah, so what I mean is, I think implicit in all of this and kind of relevant to the last question is that more dopamine means better, right? Not always. Sometimes people can experience some side effects of too much dopamine. It can actually lower the blood pressure or promote, if someone's prone to having some visual illusions or hallucinations, it might actually make that worse. And in some people, it might make them more confused. So there's always a balance, and more dopamine is not always better. So judicious means trying to find that right spot for you where too much is not detrimental, and too little, of course, we don't want, because we want to see if you can respond well motor-wise to the right amount of dopamine or levodopa.
Does Parkinson's affect motivation? Sometimes I feel unmotivated to exercise. Is this normal aging or a lack of dopamine?
Oh, great question. I think the question was around motivation, and it's hard to feel motivated sometimes to exercise. It's complicated. I don't know that motivation necessarily is a trait that declines just with aging. It's really important to keep in mind our mood and mental health. While in certain cases there are brain changes that can lead people to feeling just uninterested in doing anything, the important thing is to also recognize whether there's any mild depression that hasn't been addressed. And by that, I mean, have there been medication trials? Is therapy needed? Are there other wellness sort of exercises and classes that can be quote unquote prescribed to help promote some of that interest level? But we know it's a problem, and we know that people are trying their best. It's not always possible, of course, to get everyone excited about exercise, but we do want to start from where you are. So. Next question here. Can you address the mind processing and memory issues of Parkinson's? Yeah, we didn't go into those in great detail, but yes, we do know as we all get older, our processing speed tends to get slower, and being able to recall names of people and places can sometimes elude us. I mean, I will be honest and say that that happens to all of us, your neurologists as well. But when cognitive impairment starts to become more of a problem, if we see them in people with Parkinson's, we might notice that memory can be a part of it, but commonly another sort of way that people can find a little limiting is following sort of multiple step commands or juggling several different tasks. We call this multitasking or executive function. that can be somewhat impaired. And so for some of our patients who are still working full time, if they feel that that part of the job is affected, they might notice it, especially if their jobs are very high demand and juggling a lot of these things as we often are doing in this 21st century society. So those are some of the changes that people see. I hope that answers your question. All right. How is it decided who qualifies for deep brain stimulation? For example, why would anxiety as a major symptom not qualify for DBS? Yeah, no, in fact, anxiety is a really common and important symptom in Parkinson's. And I think that while it shouldn't be strictly exclusionary for deep brain stimulation, I think that the team that evaluates a person for deep brain stimulation, which is a surgical intervention, I should say, to the group to help sort of even out the motor complications that people can sometimes get with the medicines from Parkinson's. I think that kind of going through and setting expectations of sort of what the DBS will and won't improve. I think if DBS we'll commonly see will improve a lot of the motor symptoms, but people feel still a lot of symptom burden because anxiety is driving some other factors that may be related to quality of life that might not necessarily get better. However, there are definitely instances in which the motor symptoms and the feeling unwell is sort of perpetuating the anxiety. And once you address those things, the anxiety gets better. So it can be difficult. I wouldn't say in general that it's strictly exclusionary, but just more about that conversation of what we do expect to get better. Is that what the person with Parkinson's disease agrees, wants, and feels that that would be important for their quality of life, and then potentially addressing that if it isn't the sort of thing that DBS would actually help. Thanks for the question. How do I determine if my back pain is due to Parkinson's or aging? Wow, really good question. So it turns out in research studies, yeah, back pain actually, and pain and musculoskeletal pain is actually more common in Parkinson's than you would expect an average sample of people without Parkinson's. And I don't think that was recognized initially. Just to be clear, I think the musculoskeletal pain and the back pain is from the typical things that everyone, kind of tends to get, spinal stenosis, a disc herniation, et cetera. But we do tend to see it a little bit more commonly in people with Parkinson's. So what I tell people is, yes, maybe you are a little bit more likely to experience this because you have Parkinson's, but it's not through those molecular mechanisms that I was talking about earlier with the nerve cells and the Lewy bodies. It's not quite to that level. It's really, I think you still need to address all these musculoskeletal issues in the way that your physiatrist or orthopedist or your physical therapist would treat any other back pain related to this. So it's not to say typically that like levodopa would help this back pain, even though we do think that musculoskeletal issues are just more common in Parkinson's, probably by the nature of the motor impairments that may tend to set some people up for some imbalances in their musculoskeletal mechanics. All right. Any comments on the non-invasive vibrotactile devices like Q1 from England or PD gloves? Yeah, so these have been gaining a lot of interest. I think that there's some data out there that tactile, which means some kind of basically a vibration that one can feel or even not feel, might improve things like tremor or walking. So I think that people have a lot of interest in these because they're not oral agents. And they're relatively safe, so to speak, because they're usually typically a thing that's worn, or they might apply a very low level stimulation. I think that one thing to know about these devices, just in terms of level of evidence, typically agencies like our Food and Drug Administration, when they regulate devices tend to have a lower bar for being cleared. So just because you can buy a device like this doesn't necessarily mean there was a lot of clinical evidence generated to support that it is definitely effective. Not in the same way to the level of rigor of, say, a new drug that is developed because it goes through a much tougher hurdle to clear the bar for clinical evidence of efficacy and safety. So I think that's probably commensurate with the level of risk. Many of these things don't have a lot of risk involved compared to, say, a brand new drug that we, are just learning how it affects the body. So I have a lot of patients who are sort of interested in trying these things, and I think it's fine to try. Okay, is it true that SSRIs are not the best treatment for Parkinson's depression? I don't think we think that. I think that there were attempts to try to compare a class of antidepressants called tricyclic antidepressants and this class called SSRIs, which stand for selective serotonin reuptake inhibitors. These are things like commonly like fluoxetine or Prozac or escitalopram, Lexapro is the brand name. So they're very commonly prescribed. And I don't think that's the case. I think that's probably going to be case by case. Sometimes psychiatrists will and neurologists will select the initial medication for depression based on what other problems the patient is having. And so maybe there's poor appetite or poor sleep. Well, some SSRIs are actually better at promoting sleep or appetite than others. And so they'll select it based on that. So I find that usually sort of a tailored approach is often the best. But no, I think that SSRIs are commonly used for it. All right. How do you know when the amount of dopamine you're taking is too much? So, quote unquote, too much is when it makes you feel worse. More hallucinations, more lightheadedness, more confusion, and more dyskinesia, which are those involuntary movements that some people get. Now, some people, especially with the dyskinesia, feel like, well, they can't be mobile and move easily when they at least don't have their medication to a sufficient degree, which also causes dyskinesia. So that's when people get stuck a little bit and need a little help from the doctors to rebalance medicines, add other adjunctive therapies, or in some cases, think about the more continuous dopamine therapies or the deep brain stimulation. So might not necessarily be too much is what I'm saying. It's just that the complications of it in that case with the dyskinesias and wearing off might be just that that person might need one of the more advanced therapies. All right. I've heard about a new treatment of a patch under the skin that continuously applies carbidopa levodopa. Is that available now? Yeah. So this is actually one of these continuous therapies. The first one is called Vyalev. It's called foscarbidopa, foslevodopa. That has been approved by the FDA. The Centers for Medicare Services in the U.S. is still trying to determine the coverage of it. We expect that it should be covered. And the last we heard was over the summer. People with commercial insurances probably can get the Vyalev started now. There's a question about mood, anger, filter capacity. Yeah, so emotional regulation, I'm guessing this is a question about. I hope I will answer this uh, in a helpful way. I think everybody comes with their own history with respect to mental and behavioral health. So it's hard to answer this question generally. I think we see a lot of depression, mild depression and anxiety and Parkinson. Some of it is situational, some of it is adapting to a new diagnosis, but then being able to kind of adapt and cope and manage that well and continue to live a good quality of life. So I think this is where help is often required and hopefully available through your neurologist or primary care team to kind of connect you to mental health resources or that of the loved one. Okay, this question is about dopamine levels. If dopamine levels naturally decrease in all individuals with age, does that mean eventually everyone will be diagnosed with Parkinson's disease? Yeah, great question. So the scale of change over time is really quite small. Usually by the time someone has clinical symptoms of Parkinson's disease, we think they've lost probably about 50% of their dopamine content. So it would take quite a long time to get there. And no, I think Parkinson's disease, and it's not just about this loss of dopamine. As we all know, there's a component of these other symptoms that people will identify. Some people will have loss of sense of smell. Some people will have a sleep disorder called REM, sleep behavior disorder. These things are not strictly governed by the dopamine system. So Parkinson's is more than just dopamine. It's this collection of other unique symptoms that make up the whole syndrome. So that's another thing to keep in mind. All right, we're doing good. All right. So can you offer advice on nutrition that can help you with Parkinson's? So this is really a case-by-case basis. I think a lot of people may be aware that sometimes if you take your levodopa close to the time that you take a snack or a meal that's protein heavy, chicken, dairy, eggs, for example, they can compete for absorption. So your body wants to take up nutritional protein, but then it sees levodopa as a protein, and sometimes they compete with each other. So the way we deal with that is we tell people at least separate it. We do want people to get protein. We do need people to maintain their muscle mass. And so when this gets challenging, we're lucky that we can ask one of our nutritionists here at our center to help consult on a patient who might be losing a lot of weight and muscle and can't quite manage. So I think that's one important piece of it. Another very common question we get is, are certain vitamins or supplements necessary? They're not necessary. There's no evidence suggesting that certain vitamins will help the progression of Parkinson's or decrease risk of Parkinson's. It's been looked at quite a bit. And so nothing has really stood out to the level that requires us changing our practice. But in general, people will sometimes take vitamin D on the advice of their PCP. If they have vitamin D deficiency, that's fine. If there's probably not too much harm from taking a general multivitamin, but we don't know if it's beneficial. Biomarkers for early diagnosis of Parkinson's. Are there any biomarkers? Yeah, this is sort of like the subject of frankly, a whole nother talk. But yes, the short answer is clinically, we do have more of these. The DAT SPECT scan, the comma-shaped imaging finding I showed you, is an example of actually a biomarker that we can use clinically. The level of evidence behind it is sufficient that we feel comfortable using it to help diagnose uncertain cases clinically. It's not necessary to do the scan in everybody. We can often diagnose it just by talking to and examining the patient. Another one that's kind of emerging again, which is not always necessary, but just helpful when a neurologist might have some questions or is there some doubt because of the history or the exam, is a skin biopsy. It turns out those protein clumps that I talked about regarding an alpha molecule or protein called alpha-synuclein, you can actually detect them in the nerves of people with Parkinson's in the skin. So this makes it a lot less invasive. We don't have to do brain biopsies or anything like that. And so that is available clinically and can be useful sometimes. Those are the two main ones that are in use right now. There are others that a lot of research is going on to develop further, just to have other options for using biomarkers for clinical diagnosis. All right, I'm 78, becoming tired more recently. Find I need a nap more often. Aging versus Parkinson's. Oh, yeah. So a big topic that I didn't have time to cover is sleep. Sleep cycles frequently change with commonly with old aging, and not just with Parkinson's. Now, they definitely do change in a lot of people with Parkinson's disease, possibly because of some of the disruption to the neurotransmitters we've been talking about. Here again is an example of almost regardless of which it is, it's good to bring it up to see if you can get help with it. I think a nap during the day for most people is fine. It often can address some of the issues. But if a nap during the day is leading to more trouble sleeping at night and then feeling still tired anyway, that's when you might need a little bit of help from your primary care doc or neurologist who might recommend additional studies or behavioral interventions to try to get that sleep more regulated. All right, any data with hypnosis and Parkinson's disease? I know there's a progression in Parkinson's disease, but there's also a mental component such as fear that affects symptoms. I'm wondering if it helps with symptoms. Great question. I know that some clinical psychologists will use hypnosis for various clinical applications. I haven't heard it used, I personally haven't heard it used in Parkinson's disease, so I don't know the data for that, but it's an interesting idea. And I think maybe a clinical psychologist might have a better answer than I would. Can caffeine affect dopamine? Is it okay to drink energy drinks like V8 Energy and Cran Energy, coffee or tea? So I don't know specifically about V8 Energy or Cran Energy. I don't know if they contain like high levels of caffeine. I know some of those energy drinks out there that are kind of popular can contain really high levels of it. We don't think caffeine affects dopamine directly. But as I mentioned, caffeine seems to be somewhat protective of Parkinson's. And so people have thought, well, maybe we should test caffeine in a clinical trial of Parkinson's. The interesting thing about it is actually they did a small trial. The caffeine can actually help with constipation. It can help with promoting wakefulness, and it can make people's motor tasks a little bit faster. So I think the researchers determined it might be too hard to study this as a potential disease modifying factor for Parkinson's disease, but it is definitely okay to drink caffeine. The one thing about beverages or other foods that might contain really high levels of caffeine is caffeine definitely can promote arrhythmias, so heart rhythm problems. So definitely, just make sure you talk to your doctor about it before taking something like that has a ton of caffeine in it. With DBS, can you stop using carbidopa, levodopa? Some occasionally can. That's not usually sort of like the goal for most people, I would say, or would I recommend it necessarily being the entire goal of the DBS. But it is true that in some cases, especially I would say more common examples would be, let's say someone has a particularly stubborn tremor with Parkinson's that doesn't respond to levodopa, and they have minimal other symptoms. They just happen to have the variety where they just have a lot of tremor. Well, DBS can be very good for reducing or almost getting to zero that tremor. And so in those cases, sometimes I find people don't feel the need otherwise to take their levodopa. All right, as a caretaker, it feels as if the patient is becoming increasingly unaware or narrow on their ability to anticipate or be aware of how to take care of tasks or the needs of others, except for those that are part of his routine. Yeah, I guess what you're pointing out here is, how much awareness do they have of their own self-care needs and what they need to do. Yeah, I think that can be challenging. Sometimes you don't know. You always need to ask. Maybe person's conscious of it, but this is just sort of their way of coping with these increased needs. Or if they're not aware of it and it borders on the edge of, are they able to safely take care of these things, or do they really need help? And it could be due to motor dysfunction, but it also could be due to cognitive dysfunction as well. And so recognizing that, I think you're right in that kind of thinking about things from their perspective of are they able to recognize their own needs is important, because then you're going to be more vigilant if you're realizing that they may not always express them as they used to in the past. Okay, high PSA count. Is there a relationship between high PSA, which is prostate-specific antigen, and Parkinson's medication demand? Great question. I am not aware of an association. I have not been made aware of it. So there may not be, but I wouldn't say never. It's just not something that I think has come up. Good question, though. Can't think of a biological connection, but I'd have to go back and check. You showed a woman wearing boxing gloves. Is Rocksteady Boxing a good program for Parkinson's? So yeah, you're referring to Rocksteady Boxing, which has become this really very popular franchise of boxing clubs that many of my patients enjoy. Now, that being said, some people, I'll mention it, and they're not interested. So I think that there's probably some it's intuitive that I think exercise in general and promoting physical activity by making it fun, being part of a group, promoting social cohesion and interaction is probably good. And if it gets you more physically active, that gets us more towards that general goal that we talked about in terms of promoting physical activity. So I think if you enjoyed it and you have one nearby, you like going, that seems, and it makes you feel good, I think that sounds like it's good for Parkinson's. Okay, tell me more about how carbidopa levodopa can affect vision. So not not to any significant degree to my knowledge. I think that one thing we didn't talk about today is sometimes people will notice trouble focusing on close objects. That can happen with aging, but it can also happen increasingly with Parkinson's. And that's sort of an eye muscle coordination problem. But I'm not aware, nor do I think many of my patients report too many problems with the levodopa and their vision. So I'm not sure if that's helpful, but that's what I had to say about that one. All right. Do pain medications like Advil and Tylenol interfere with carbidopa and levodopa? Nope, they should not. Those are safe to take with carbidopa, levodopa. Can you talk about functional health? How can we get better our cells to achieve better function? Yeah, this is an active area of research. I don't think we have the answer yet on how do we get our cells to function better. I think that's part of the research behind the biology of Parkinson's and knowing how complex it is biologically, actually, it's a bit of a challenge. So more to come on that. I'm not sure that we know yet. I think that all the trials that we've done in the past with supplements or new drugs that have been designed from the lab are designed in the hopes of making cells survive and function better. But we haven't clearly demonstrated to the point that we can recommend them universally for slowing progression of Parkinson's yet. How do non-motor symptoms influence disease progression and prognosis in Parkinson's disease? So the probably the biggest factor here is if some patients do have cognitive impairment and it presents early on and it continues to be progressive, that's in some ways I think indicates that might be a pretty different experience from someone who really has just really motor symptoms and no cognitive symptoms whatsoever for a long time. And so we do tend to see these. There are a fair number of people who I would say do have Parkinson's disease with motor symptoms, but a fair amount of cognitive symptoms as well. I think that to be sure, I think non-motor symptoms do influence maybe more than progression, I would say quality of life. There's a lot of research indicating that, and that it's not just a motor disease, but the non-motor symptoms greatly influence the quality of life and the lived experience of that person with Parkinson's. And so that's just something to be aware of as people get their care for Parkinson's, that you have to address both the motor and the non-motor to try to help that person feel and function better. All right. Any trends related to driving safety and PD? I wouldn't say trends, but we've known now for some time that driving is actually a cognitively complex task. So scanning an area, reacting at the appropriate time, making judgments about when to go, when not to go. These things can be compromised, whether it's in Parkinson's or aging or even Alzheimer's. Driving safety is also a big issue in Alzheimer's because of the cognitive problems that can make driving a problem. What I would say is that there used to be a lot of sort of driving evaluation programs in the community. There are probably a couple remaining, but they're not as common as they used to be. But if you have concerns, talk it over with your loved one and family members who may be observing you driving, or if you are a family member, observing your loved one driving to see if you see any observations that make you concerned about it. I think ideally we arrive at sort of a mutual decision about when it might be time to curtail driving or give it up, because that certainly is something that can lead to more problems if you were to get in an accident related to not being able to drive safely. Cold hands and feet, is this a Parkinson's symptom or aging? Good question. I think it's probably not uncommon in aging as well. I don't have statistics for you. I haven't looked at that. It's a good question. Some people with Parkinson's will say it, but I think some people as we get older will also experience it as well. So not too sure how different it is between the two groups. Good question though. Is it true that older age of diagnosis indicates faster progression? It may not indicate faster progression. It could be that it reflects that, by the time of older age, the brain is aging already, as we talked about with the factors that I already explained. And so aging of the brain, and then developing something that looks like Parkinson's disease on top of it. It could be that for a number of reasons, it's a little speculative, but it could be that maybe the brain is going to be, perhaps less resilient. It isn't a foregone conclusion, but I'm just saying that it can be harder because of that. It can be harder because it's maybe harder to do some of the things that you would do ordinarily to, for example, rehabilitation. Maybe there are other limitations to getting exercise, whether it's other medical problems, joint problems. So for these reasons, it can sometimes be harder. It doesn't always mean a faster progression. It doesn't always mean a worse quality of life. But we have to recognize when these challenges are there and just kind of think creatively about how to address them to help people, again, kind of start from where they are and help them get a little better. Regarding non-motor skills, it also impacts the caretaker as a patient, as the patient becomes less aware of how they participate in pitching in or engage and recognize the needs of others. Yeah, I agree. This is always something that we want to keep sort of in mind as we see patients in the clinic, that their care partner also is observing things and finding that, maybe at first they felt like it was just taking care of motor tasks, but now they're realizing how much of your brain normally acts as sort of like a conductor, where you're overseeing all your needs and your awareness of all your needs. You're thirsty, you need to drink, you feel a sensation in your bladder, you need to get up and go to the bathroom. All these things might become a little bit harder to recognize and plan for. So I agree with that. Is there a way to tell the difference between dial dystonia and TMJ? Not sure that this is related to Parkinson's, but probably requires a little bit more examination by an oral health specialist and or a neurologist if the oral health specialist feels that that would be helpful. Can acupuncture help with bradykinesia or muscle stimulation? I'm not aware of any data that suggests that it is. I think acupuncture has shown some benefits in relieving pain in all kinds of other medical conditions. And so, not uncommonly, I'll have patients try to see if they feel a little bit less muscle discomfort or pain. It doesn't seem, again, one of these things that doesn't have too many adverse effects. But I'm not aware that it should help with bradykinesia, which is the slowness that we talked about. So how much carbidopa levodopa can someone take daily? And are there newer medications of Parkinson's that have less side effects? And if so, does insurance cover them? So, I think one thing to keep in mind is that carbidopa levodopa has been around a long time. It's been approved by the FDA. It was approved by the FDA in 1975. So it's been 50 years now. It is in some ways still our gold standard. What some companies have done over the years is tried to take that carbidopa levodopa and make some longer acting formulations of them, or not just longer acting formulations, but better absorbed so that they kind of have release a little bit more evenly in the bloodstream. And while insurance does cover them, they can be more costly compared to the generic carbidopa levodopa that's widely available. And then we talked about, I think, the continuous infusion. This is sort of a needle under the skin covered by a patch. This is, again, sort of to help deliver a form of carbidopa levodopa to apply it more evenly. So then getting back to that question of how much can one take, there's no one hard answer for any person. It might be quite different from person to person. I have some people who cannot tolerate, more than the equivalent of like 3 pills a day, which is sort of 25/100, 3 pills of carbidopa levodopa. And then other people who require many multiples of that to keep their motor fluctuations or on and offs more even keeled. So I think that it's one of these things where it's got to be a conversation with you and your healthcare doctor. And then as you try the medications and increase medicines, if you reach a point where it's clearly having side effects, then you have to really back down and kind of reassess, how much levodopa that might be too much for you.
I think one of the very last questions in there is just, could you repeat the name of the medication that helps with tremor?
Oh, I'm not sure that I said specifically, except maybe when I was talking about Some people have a very stubborn tremor with their Parkinson's. And in that case, deep brain stimulation is a surgical treatment, which can basically place an electrode and connect it to like a pacemaker that helps gently stimulate that area of the brain to control the tremor. So this is usually for tremor that hasn't responded to carbidopa, levodopa, or the other dopamine medications. Sometimes people will use another non-dopamine medication like amantadine just to see if it helps the tremor. Occasionally, I've seen people use propranolol, but basically, those are the I think what I may have been discussing was the surgical intervention. I hope that helps clarify sort of the range of options there. All right. Well, you've been a terrific audience. Thank you for all the questions. Thank you for attending. I hope this was useful, and hope you have a wonderful rest of your weekend.